Thank you. I could use a very loud. Someone once told me if you just talk really quietly, then everybody will stop talking so that they can. But I'm usually a very loud talker. So, well, good morning, everybody. My name is Stacey Lindau. I'm going to introduce myself, which is great because I hate those long, wordy introductions that you can just look up, you can just Google it. so I'll just be short and sweet. I'm a professor in the departments of OBGYN and medicine, geriatrics at the University of Chicago. I've been there 19 years. It's a long time. Renata and we have 19 years behind us in our current jobs, we discovered this morning. And I'm so appreciative to be invited to talk with you about treating female sexual function concerns. I'll draw on my experience caring largely for women with cancer who present with sexual function concerns. But as I was just saying to a colleague, if you can address sexual function problems in women with cancer, you can address sexual function problems in any woman because it is more complicated. I brought a couple gifts for you. They're over here by the gourmet cupcakes, which we don't see in Chicago at Grand Rounds, but one is a save the date for a conference of the Scientific Network on Female Sexual Health and Cancer. This is an organization that I helped to found with colleagues at Memorial Sloan Kettering Cancer Center, going back now about 10 years, because there was no professional organization that was specifically devoted to this particular group. So our next meeting is at Ohio State in October. It's a great time to be at Ohio State, and there are cards there. And then I'm going to talk a little bit about a resource that my lab has created with foundation support called Woman Lab. It's everything we know, all of our clinical tools, blogs written by me and my research team and my patients on topics related to sexual function, cancer, and we're branching out into other conditions. We also study sexuality in the context of cardiovascular disease, dementia, et cetera. And so it's a public resource. Just shortly before I turned 50, I felt like I better get everything I know out there quickly. So this is what I'm attempting to do it. And you may use it liberally. And if you have ideas about how the materials could be better, there's an easy way to contact us and work with us. So feel free to take a card. You've had a moment to look at the learning objectives, and I hope to achieve these. Certainly, I would welcome feedback at the end of the lecture if there's something I miss. I have no conflicts of interest to disclose regarding this, the topic of today, but I do acknowledge some of the funders, especially for Woman Lab. And I've already mentioned Woman Lab, but who we are scientists and clinicians, researchers, patients who are eager for the world to understand female sexual function based on the best available science. And it's targeted toward everyone, women especially, and those who love and take care of women. So about 25% of the users are men, and with organic growth only. We have no marketing campaign for this other than my scientific publications and public speaking. We have reached in about 18 months women in every country. Madagascar was the holdout. We now have 3 people in Madagascar and more than 70,000 people. So I think there's a real need for this kind of expertise. My clinic volume has gone down since we launched this platform, and I just said to my team, somebody run a regression analysis because I think we're putting ourselves out of business. So much of what women need to know to recover their sexual function or to manage sexual function problems is knowable from a website. And only a tiny fraction of women can get access to highly specialized care like you can provide here. And so I really think by putting the information out, a lot of problems people can solve largely on their own. So this is what our program looks like, and I share this with you both to highlight the beautiful and wonderful people who I work with, but also to give you a sense of what I think is needed to operate a comprehensive, holistic program for women with sexual function problems. As you see, the diversity of specialties and people, a unique role that we've created is a patient educator role. So these are usually recent bachelor's degree graduates, science graduates, who are trying to figure out, are they public health professionals, are they doctors, are they nurses? What path do they want to take in healthcare? So they come to the lab for a minimum of a 2-year commitment. They conduct research with us, and they learn protocolized ways of educating patients about some of the common and basic things. So it's been a great role, and we've had many people go off. Actually, one of my patient educators, Chenab, maybe you'll see her here in Boston because she's matriculating to a PhD program at MIT in just a couple of months. So I'm so proud of her. So we have a registry, a prospective registry. We ask all of our patients to participate. About 80% do. Here you see that 27% of our patients have no cancer. These are usually patients coming from general gynecology, where they just don't have the same time with patients to go deep on the issues. So general gynecology will attempt to address the issues, and if they hit a problem, they'll come to me. I don't practice general gynecology at this point, so I work with the general gynecologist. And then, I'm sorry, it looks like there's a little formatting problem on that blue part of the pie, but these are the cancer types we see. And point being that really any systemic treatment for cancer, any treatment that affects the functioning of the hypothalamic pituitary ovarian axis, any treatment that affects the ability, think about head and neck cancers, it's really hard to kiss if you've had radiation to the head and neck and you have scarring and pain or dry mouth. Of course, gynecologic cancers, you can imagine how they might interfere with sexual functioning. Breast cancers, and I just want to acknowledge, whenever I talk to an audience of people this age and with we've all been touched by cancer, and breast cancer in particular, and there may be even people in the room who've been treated for cancer. So I want to acknowledge that. What I know from caring for women with breast cancer, for example, is so even though we can reconstruct a good-looking form of the breast, my patients say it looks great in a sweater, we've done very little to address the functioning of the breast. And loss of breast sensation is a really distressing mechanism for loss of sexual function in many women. That's an area of our research. So what does sex and cancer have to do with each other anyway? Well, it turns out the vast majority of cancers men and women survive directly affect the sex organs. You might not have thought of it that way, but 2/3 or more than 5 million female cancer survivors have had a cancer that directly affects the sexual organs. And for men, of course, prostate cancer. Now, in male prostate cancer care, every time I say this, I have men tell me it's still not what it should be. But in male prostate cancer care, we do have a way of saying to men, if we choose this treatment, this will be the effect on your urinary, reproductive, and sexual function. But if you choose that treatment, these will be the expected outcomes. And men can actually make treatment decisions about their cancer based on how they prioritize these various aspects of their function. But think about when you've counseled a patient regarding her gynecologic cancer treatment, or she's been counseled about her breast cancer treatment. How often do we bring expectations about sexual function to the decision-making about which treatment? We really don't yet. We could. It's been proven, because we could do it for men, we could certainly do it for women. But not talking about it, which I think, we good doctors avoid talking about this topic sometimes because we're worried it's too sensitive, it might be too overwhelming, family members are in the room, so you can't really bring it up. We're doing it for protective reasons, not hurtful reasons. But when we fail to mention loss of sexual function, which affects, it depending on the study and the cancer type, 35 to 75% of women who've been treated for cancer, when we fail to mention that it might be an outcome of cancer treatment, women believe when they have these problems that it's just them, or that it's in their head, or because surely if it were a common problem, somebody would have mentioned it. And we do counsel women about much less common problems like the risk of death due to anesthesia or injury to the bowel and bladder, and but those occur at a frequency that is a fraction, orders of magnitude less than the problem of sexual function. So let's just talk quickly, like some definitions here. The interactive biopsychosocial model is the way we framed both our research, and I think it's a really helpful tool if you're getting started and talking about this issue with your patients. So the biopsychosocial model. Our medical schools are organized around it since the early 80s. This is George Engel's work. He was a psychiatrist who described that health, or the understanding the health or illness of a patient, requires understanding the biological, the psychological, and the social domains. And so we built on that work in developing a national population-based study of sexuality and aging. We built on Dr. Engel's work and expanded the model and called it an interactive biopsychosocial model. The point being, when we're studying sexuality or when we're treating sexual dysfunction, it's important to understand not just the biopsychosocial of the patient before you, but if there's a partner, what's going on there. And it's not uncommon that the problem that needs to be addressed is actually the partner's erectile dysfunction. Like there's dyspareunia or there's difficulty with penetration, not because the patient herself is dysfunctional, but because the partner doesn't have a full erection. So if I don't ascertain that, I can't get to the root of the problem. Another example, I had a patient with recurrent vaginitis. She'd been everywhere. She'd been really suffering. And by using this model to take a history, it went like this. And do you have a partner? And is your partner healthy? Is your partner taking any medications? And it was with that question where she revealed that her partner had been on increasingly higher doses of methotrexate for rheumatoid arthritis. And when we think about it, it was the timing of the methotrexate that correlated with her vaginitis. And does methotrexate concentrate in the semen, or could it be sexually transmitted? Yes. And with condoms, change in their sexual practices, vaginitis improved. Sexual transmission of pharmacologic metabolites and even the metabolites from tobacco is a real thing. So tobacco metabolites concentrate in semen. And when we think about HPV and smoking as cofactors for cervical cancer, you got to understand that the toxins are not just through secondhand exposure by inhalation, but they're in the semen itself. Very little work has been done on that. It's a good way to motivate partners to stop smoking, by the way, because I've had several male partners be like, what? That's disgusting. And I'm like, well, stop smoking. It's not a problem anymore. I share with you quickly the physiology of the sexual response cycle for males and females. And the reason why I think, especially for those of you who have to take your CREOG exams, I mean, things may have changed in 20 years, but this was the only question regarding sexual function on my entire CREOG exams for my whole career in residency. And it was, what are the phases of the sexual response cycle as defined by Masters and Johnson? So this work was done at Washington University in the 60s. This was physiological studies. You've probably also heard of Kinsey. And the Kinseys were doing social survey research. So we had the biology studies and the social survey studies complementing each other. The important thing here is that the male pattern sexual response cycle was pretty uniform. The real difference being the time period between when a man could have another ejaculation, this refractory period, that can change over the life course for men. And the female sexual response cycle was more variable. And one important thing to note is one of the patterns is a flutter pattern. It looks like atrial flutter. It looks like an NST in labor and delivery. But women don't recognize that pattern. Some women don't recognize that pattern as orgasm. And so what they're imagining as orgasm is two things. One, the way it looks in the movies. So Hollywood image of orgasm, especially if they've not had sex education. They didn't have a mom like me who just told them the way it is. I have only sons. They know a lot. They know way too much about all of this. Hopefully they'll put it to good use. But so in any event, and then the other thing, women have the understanding, and again, this I think comes from the Hollywood image, that if it didn't happen with penis in the vagina or dildo in the vagina during sex, it wasn't an orgasm. So like if she had to have the orgasm after intercourse or before intercourse, it could only happen with foreplay or it could only happen with masturbation. It's somehow a lesser orgasm. And so people carry these beliefs around, and again, back to the education, we whip out Masters and Johnson. By the way, does anyone know who were the subjects for this research?
Themselves.
Pardon? Themselves, yes. And the biggest part of the cohort were sex workers in St. Louis. Why? Because they were thought to be the sexually liberal enough ones to get hooked up to physiologic machines. But then doctors and nurses and staff at WashU were also active participants in the study. Okay. So DSM-5 gives us technical definitions for sexual dysfunction. Are these important? Yes, they're important if you're a psychiatrist. They're important if you're doing research like drug intervention research and you need to classify people technically. But people don't have to meet this definition in order to qualify for having a problem or being treated for a problem. So a person might have a painful penetration that only started 3 months ago. Well, we obviously don't wait for 6 months before we treat it. So these are technical definitions, and they're helpful to know. But in practice, in gynecologic practice, there are plenty of ICD-9 and 10 codes for all of these conditions that don't require meeting of these criteria. And actually, that's true for the DSM-5 criteria in general, right? Plus, somebody could have anxiety or depression. They might not meet the technical criteria, but it doesn't mean you can't acknowledge and address the problem. Okay. Well, other thing I'll say here is important to know that a change from the DSM-4 to the DSM-5 was a lumping together of interest and arousal disorders. They were separate, and now they are together. And if you go to the sexual function meetings, there will be hearty debate among everybody. Some people are very bitter about this. The problem with it in practice is, for example, when we look at the studies of the new flibanserin, a drug marketed to address libido problems in women, the outcomes were based on definitions when these two things were separate. Now these two things are together. And new studies will have to look at outcomes with a combined measure and how do we make sense of what these studies are finding over time. So these definitions are helpful for research, but also as they change can create some translation problems. So how do we elicit sexual function concerns? I mean, some of you have had the experience, I'm sure, where a patient comes in ostensibly for her annual exam and you do all the usual things. Thank you very much. And then you open the door, you step out, and she's like, and wait, one other thing, it really hurts when I have sex, or my libido's gone. And so the first thing you do, of course, is close the door, okay? But you're not going to panic because you are going to not feel that you have to address this problem today, but you're going to have a way to address it. I'm going to give you some tips, okay? So first of all, when we're assessing for sexual function problems, I think that the best available evidence, the accumulation now of decades of evidence says we have to assess routinely. We can't look at a person and say like, oh, you look sexually active. Oh, you look like you don't care about your sexual function. It's just impossible. There's no algorithm the algorithm is this. Everybody cares. And we've done the research to prove this. Okay, not 100%, there are some people who don't, but even a person without a partner in her 80s still feels that having the potential for sexual function is part of her overall wellness, it's part of her body and her identity, and it may not be a problem she wants you to treat, but assuming people are asexual is a wrong assumption almost all of the time, okay? So here are just some examples from our own work, but if you looked at the world literature, you could find hundreds of these examples to substantiate the claim that most people care about their sexual function. What about lung cancer? A terminal illness, although actually since we did this study, the prognosis for lung cancer is even better than it is better because of new treatments. But in this study, people with less than 6 months of life tell us that they believed sexuality and intimacy was important to their relationships, and some of them wanted help to be able to continue this aspect of their life, even with lung cancer. In our study of sexuality among older adults in the United States, this is a national probability sample, ages 57 to 85, more than 3,000 people, funded by the National Institute on Aging. 80 to 90% of partnered Americans ages 57 to 85 are sexually active, and there's really not much difference among partnered people by age group and who cares about their sexual function. And we just published a paper looking at sexual activity behavior problems among community residing people with cognitive impairment and dementia. And by the way, that population is growing fast. Most of what we know about sex among people with dementia is from the nursing home literature. And it describes the problem of sex in nursing homes because it's a problem for staff. Here we see that more and more of the population with dementia is aging at home. And a lot of people are sexually active. This raises ethical issues. In some cases, it's even raised legal issues. Do we treat people to prevent them being from, do we castrate people so it's not a problem at home? Or what do we do? But most people care about their sexual function, okay? So how do we assess for it? Well, there have been studies looking at how best to assess and validated measures, and I'll share that with you. In our practice, the best we could do when we started 10 years ago was add this one item to our intake form, and this is from our intake form for our new gynecology oncology patients. Now, once again, if you can do it for cancer, you can do it for everyone else. If you convince the G1 oncologist to do it, you can convince everybody else in the department to do it. So the G1 oncologist who actually asked me to start this program, Dr. Diane Yamada, actually supported me and asked me to get this program up and running. They added this problems with sexual functioning to the checklist for new cancer patients. If nothing else happened, every one of those new cancer patients now has seen, oh, somebody cares about my sexual functioning. It's a legit topic. If I have a problem, I could bring it up. That in itself might be therapeutic, okay? You got to recognize and address the problem, though. We saw a gap in a study we published. Emily Hill, who's a GYN oncologist now, but then was a trainee, saw that twice or three times as many people indicated a problem as actually got addressed during the visit. So that gap is a problem, but you got to start somewhere. And here's like the validated measure. This is using the patient-reported outcomes measurement information system. Catherine Flynn is a tremendous psychometrician at Medical College of Wisconsin, trained at Duke. And this is a single item checklist that can be used for men and women. It's very efficient, and it's been validated in a whole range of populations as a systematic way to assess sexual function. What do you do if sexual function concerns arise? Keep calm, Carry on. You do not have to solve a libido problem on your way out the door. But this is what you can do, because what you can do is recognize the reason she's asking you when you're on the way out the door is because she was terrified to ask you. She's embarrassed to ask you. She doesn't want to waste your time with this petty question. And that's what's in people's head. But they're really suffering. Really, that goes for any question that gets asked when you're on the way out the door. Like, they came to ask you that for the most part. So all you need to do is close the door and say, I'm so sorry, I should have asked you about that. That's, of course, an important part of your health. Libido problems are a really common problem. You're not alone. It's not your fault. I can help you. Or I know a colleague, down the hall who is really interested in this. There's help for you. Would you be willing to come back for another visit? And if you want to see the patient yourself, this is great, because now you know what her problem is. You can go look it up or call me or, your experts here and be prepared for the next visit. And I would say for a sexual function visit for a patient without complex comorbidity, a 30-minute visit is really what you need, because it takes time to sort of warm up, just to get out the information. For a complex comorbid set of conditions, we have an hour with patients. We only see them 2 or 3 times and they're feeling better. We could do that over 10 visits in 7-minute chunks, but I think a 30-minute for a first-time sexual function concern that's devoted to that problem is really what you need, at bare minimum. Then you ask the patient, would she return for a focus visit? You could refer with a quality handoff to a specialist. Quality handoff doesn't have to be laborious. It could just be calling your expert and saying, I have a patient with this problem. This is what I know about the patient. Would you take care of her? More complicated patients need something more. Do not suggest to the patient that you think the problem is in her head. It happens regularly. I commonly see patients who say, my doctor just said I'm too stressed out. They said I should have a glass of wine. It's really in my head. I'm not trying hard enough. Okay, and these are patients who clearly have iatrogenic sexual dysfunction. Part of their clitoris has been removed for vulvar cancer. Their breasts no longer have sensation. This is not in your head. This is, you chose treatments to treat your cancer, but these are iatrogenic problems. We cause these problems and we forgot to tell you that they might occur. That's a real frame shift for people. Removing the blame is really important. Women come in feeling very ashamed, very culpable for these problems. And so I never say it must be in your head or are you depressed as a first response, but I do say, why do you think you're having this problem now? And patients, you oftentimes have the answer. We are going searching for answers and they actually know the answer. And sometimes they'll say, you know what, I'm really depressed. I don't want to do anything. I don't even have a good appetite. I don't want to go out with my friends. And I think this libido problem is just one of those symptoms. Patients will say that. Great, then can we first address can we get you help for the depression symptoms? Because if we address your depression symptoms, maybe your libido will improve. So, happy to answer questions about that. As you all know, a little complicated because some of the antidepressant drugs also suppress libido. But I will maintain, and I think the literature supports this, untreated depression is worse for libido than treated depression, okay? What about the physical exam? Is there a role for physical examination for a woman who presents with sexual function concerns, or can we just treat it without the exam? We cannot treat sexual function concerns in women without an exam. And there are a lot of healthcare professionals out there who are fully assessing and treating sexual dysfunction in women without a physical exam, and I don't think that is best practice. We have published in Cancer, and this is clinician scientists across disciplines, including physical therapy and psychology and gynecology and oncology. Our idea of best practice for physical examination of a woman who presents with sexual function concerns, it's geared toward women with cancer. It works for women without cancer too. It is important to communicate to a woman, I think in general, but especially when you're assessing sexual function concerns, that the physical exam itself should never be a sexual encounter. There is nothing about the exam that is intended to try out her sexual function. And just a side note on that, some women present saying, I don't know how to masturbate, or with building some trust, and you get to the point, I don't know how to masturbate, or I've never had an orgasm. I feel like a very experienced clinician in the realm of treating sexual dysfunction. I have a boundary. I am not going to teach a woman masturbation in my clinical office. I'm not going to stimulate her clitoris and I'm not going to have her do that under my supervision. And I'm interested if you have ideas about that. I just don't see that it's that it can be clinically appropriate to do that. And by the way, OBGYNs and psychiatrists are the two physician types most likely to sexually abuse their patients. There are clear ethics around sexual relationships with patients, and the ethics say no. Okay, and so it's important to say why I'm doing this exam, what you're going to learn from this exam, and the exam's not intended to be a sexual encounter. Side note, it is not a breach of professional ethics to yourself feel sexually aroused in an encounter with a patient. Sometimes that happens. It is a human experience. The problem is if you act on that sensation. So becoming aroused is not out of bounds. Acting on arousal is out of bounds. And sometimes a patient can become sexually aroused. So in saying to her it's not intended to be a sexual encounter, you also don't want to shame her should she feel sexually aroused. It is advanced clinical care. It is, and it requires advanced communication skills. One of them is just getting used to saying all these words out loud in front of people. So you're going to do the exam to identify and inform the patient of normal and abnormal findings. A lot of people with sexual dysfunction believe that there are anatomical aberrations, congenital defects, tumors in their vagina. You know, they're really worried about the abnormal findings. I use a hand mirror. I give people a map of the anatomy, happy to share that map, and I educate them. These are labia majora, these are labia minora, there's the clitoris, here's the hood of the clitoris, you know, just so they know the anatomy. Yes?
Do you have a chaperone with you at all
I
times?
do. My patient educators serve as a chaperone, and the topic of chaperones is another. I teach in our ethics center, and there's a really interesting way of thinking about chaperones. Ideally, it would be a person of equal power to the doctor. It never is. It's a medical student. It's a patient educator. You know, it's a nurse. It's, you know, that's really the intention of chaperones, but I never do an exam without one, and I need an extra pair of hands to just get through it. I have once had a patient say she did not want the chaperone. And I excused the chaperone to have a conversation with her, and I explained to her why I needed a chaperone. One was the pair of hands, the other was for both her and my safety. And she agreed then to go forward with it. But it's rare that someone would refuse. Men doctors are much more likely to have chaperones than women doctors. So which is also an interesting discussion. I have so many things I want to tell you about, but we'll keep forging ahead. So when to forego the physical exam? Adolescent patients rarely present for sexual dysfunction, although if they've been treated for cancer, they may be having pain, difficulty with inserting a tampon. Sometimes those patients come to see me. Sometimes patients come because they're worried about starting a new relationship and they want to know, is everything working down there? So it's sort of like, let's inspect and detect, and they might need a physical exam. But in gynecology, generally, the adolescent does not need an internal exam. If a person can't tolerate the exam, you know, forcing them to have a painful exam when they're presenting with painful sex doesn't make a whole lot of sense. So we sort of therapeutically move toward the exam as one of the outcomes of treatment. And near the end of life, you know, I've had patients who have metastatic, you know, end-stage breast cancer, but want to be sexually active with their partner. We don't need to do a physical exam, and we don't need to withhold estrogen, for example, in that case. In fact, in some cases, high-dose estrogen is being used to manage metastatic breast cancer. So what are some common primary diagnoses? I obviously can't cover all of sexual dysfunction, but I'll try to stick to the common things. Dyspareunia, the Latin translation is painful lying together. And dyspareunia is a very common motivator for people who come for help. It includes conditions like vaginismus. I'm going to give you a schematic way of understanding vaginismus, very simple. There is some controversy over the term. I still think it makes sense as a term. High tone pelvic floor dysfunction. So we're much more likely in my practice to see high tone in the pelvic floor rather than laxity as the problem. That's because many of my patients are younger, and with cancer, they're not coming because of prolapse. Those patients are oftentimes presenting to our urogynecologist and then may come to see me. But laxity is usually, you don't oftentimes see laxity with dyspareunia unless the mechanism is low estrogen, and relatively straightforward thing to address. Vulvovaginal dryness, inflammation, contact irritant dermatitis is very common, and of course vulvovaginal atrophy. Loss of or diminished libido is another common problem, bothersome to women, and acquired difficulty with arousal and orgasm. I really haven't seen primary anorgasmia. I really haven't. If anything, it's been an educational issue and corrected with education, but not like a central nervous system disorder that prevents somebody from having an orgasm. Comorbidities are common. This is why it takes time to fully assess these patients. And these are the kinds of comorbidities I see in my practice where I have predominantly cancer patients. What I love about this practice is it draws on my training as a surgeon, an obstetrician, a primary care doctor. It really keeps you current on a broad swath of the practice of medicine. And I personally find that very challenging and satisfying. I put abuse as number 10 because one of the other messages women get when they present with a sexual dysfunction concern is that they must have been abused. Just like we sort of too quickly go to, are you depressed, are you too stressed, we also go to, do you have a history of abuse? We should assess for abuse, but we should do it recognizing that we don't want to suggest to a woman, oh, you're having difficulty with your libido, you must have been abused as a child and you blacked out and you've forgotten all about it. I've seen that multiple times, and women have already gone to their sisters and their mothers saying, like, I think I might have been abused, was anybody else? And you can imagine the trauma in families. Yes, abuse is a common problem, but it's not the most common cofactor in sexual dysfunction. So let's just look at some data. This is from our registry. Our colleagues at University of Wisconsin-Madison has replicated our program there, including our registry. So we now have 2 site data that were just presented at the SGO meeting. The data are quite similar. A fifth of our patients who present with sexual dysfunction and cancer have a history of abuse. The population estimates are 30% of ever partnered women worldwide have a history of physical or sexual intimate partner violence. Those, by any standard, those numbers are abhorrently high. I mean, it's outrageous. 30% of women have had history of physical or sexual intimate partner violence. And just like I acknowledge that there are people who've been affected by breast cancer, we also have acknowledged that some of us in this room are also victims of abuse in our relationship. So it's a very serious problem, and I'm not trying to discount it. But this means that somewhere between 70 and 80% of the women who present with sexual dysfunction problems have not been abused. So over-attributing the sexual function problem to a history of abuse is just not good. It's not founded on good evidence. So what about dyspareunia? This is a schematic way of understanding what happens with painful intercourse. Now, most women don't come to sex with fear unless they're in a relationship, they're maybe a new relationship, there's some uncertainty, it's their wedding night and they've saved sex for marriage, they're in an unsafe situation. But if you've had cancer or other surgery or a heart attack and you haven't had sex yet, you sort of approach the event with a little trepidation for a lot of people. So there's a little bit of fear, but there's a desire. I want to get back to this, and I actually feel ready, and I can get aroused. There's an attempt at intercourse, and then there's pain. And the pain is exactly what I was fearing to begin with, so then what happens? The fear goes up, the desire goes down because our brains are programmed not to desire pain. It's harder to get aroused because that physiology I showed you doesn't play out the way it ought to, but we try anyhow thinking it's going to work this time, there's more pain, and so the cycle goes. This is a very common way things play out with dyspareunia. So dyspareunia then doesn't happen alone. Dyspareunia is oftentimes presenting with loss of desire, loss of arousal, loss of orgasm. What's the difference between desire and arousal? Very briefly, desire is the like having sexual thoughts and fantasies, like, oh, I really can't wait to get home to see my partner, or like thinking about sex, having drive, libido are words synonymous with desire. Arousal is the genital, mainly the genital physiology, the sensation of like, sex, like the physiology is beginning. People will describe it, women will describe it as getting wet, or as a tingling sensation, or a throbbing, as a pulsing sensation, but it's more that physiology in the genital area. And if you can't get aroused, it's very difficult to have an orgasm. If there's pain, the pelvic floor muscles, the levator ani muscles, the muscle around the opening to the vagina, which we're going to talk some about, tighten up. And when those muscles tighten up, what happens? It's hard for the blood vessels to traverse and deliver oxygen to the little small nerves that are at the end of this system. And therefore, people will say, I feel numb down there. I can't get any sensation at all. And oftentimes it's a mechanical problem. It's just the strangulation of the blood vessels and the nerves and the hypertonicity in the pelvic floor. And the good news about that is it's correctable. Pelvic floor physical therapy is an effective intervention to address hypertonicity in the pelvic floor muscles. And when we address that, it's a plumbing problem. You can get better flow and better sensation. And I wish it were that simple, but that's a big part of how things work that I did not understand as a result of my training, really had to learn over time. So let's talk about vaginismus. Okay, this I give you as the single most fascinating and important thing you're going to learn today. Maybe you already knew it, so just reinforcement. We all know about the anal sphincter, bless you. Everybody has one. We use it, hopefully once a day for most of us. And then, and we know that to use it, sometimes you got to have a Valsalva maneuver. You got to bear down a little bit. Why? Because it's a sphincter muscle. And the definition of a sphincter muscle is that at rest, it's slightly contracted. Its job is to hold things in. Okay? I never realized this. But there is another sphincter muscle in this picture, and it is attached to this important sphincter muscle. This muscle is called the bulbocavernosus muscle. If you go back to the old anatomy textbooks, it's called sphincter vaginae. Now, Jennifer Gunter, anyone follow her on Twitter? We've engaged in a little bit of a debate about this. She does not believe that this is a sphincter muscle. And I've pointed to the historical anatomy text, so we didn't resolve our differences. But this is, I interact with this muscle all day, every day, and it acts like a sphincter muscle. So you could choose which of us to believe. I'm telling you there's a debate. But to me, when I say vaginismus, what I mean is this muscle is hypertonic. This muscle responds in a vigorous way to anticipated penetration or actual contact or penetration. And when it responds, it thickens up. Okay, it gets thick and hard, and it feels like a wall. And that's what patients say. I say, well, what's the problem? Well, it's painful. When? With early penetration or deep penetration? By the way, if it's painful with deep penetration, you should have a high index of suspicion for a neoplasm. Pain with deep penetration as a new symptom is a worrisome symptom. I almost never see it, and I rarely get ultrasounds or other imaging in my patients. Those are the patients who have a finding. Now, if there's granulation tissue after hysterectomy, okay, we can think of reasons why it's expected, or there's endometriosis, whatever, but never had deep dyspareunia, now have deep dyspareunia, take it very seriously. Pain with penetration, you say, well, what does it feel like? Well, when he goes in or I try to put something in there, it feels like I'm hitting a wall. And what does a person with cancer think when you're all of a sudden hitting a wall in your vagina? There's cancer in my vagina. That must be what it is. And my partner thinks that too, because I also bleed when we try to have sex. So, and then I say, well, how far in? This far in. Try it. You'll get the exact same thing. And they say, I feel like I'm scarred shut. I feel like I'm a virgin again. And if people have had surgery or chemotherapy or certainly radiation to the pelvis, they believe their vagina's just gone, that they've been scarred shut and it will never come back. And that's almost never the case. So here's just a simple way, layperson. I gave a talk at the Aspen Institute last summer to a mixed audience, including teenagers. And I had to explain this the way everybody could understand. At the resting state, this muscle is slightly contracted. In order for it to be open, something has to happen. The physiology of sexual response, the physiology of arousal, subconsciously releases this muscle and opens it for penetration. When a person feels under threat, when she feels fearful, when she's had pain, the muscle does the opposite. It contracts, it's tight, it's closed. And this is why rape is such a physical act of violence. It takes a lot of force to burst through this muscle. Now, Valsalva also helps to open this muscle. And where do we see that all the time? In labor and delivery. When we're saying empuje, push, what we're doing is generating Valsalva, yes, obviously to help move the fetus through the birth canal, but we're also creating intra-abdominal pressure that then helps to open this muscle. So the safe and happy and loving zebra has an open bulbocavernosus muscle. The zebra under attack has a tight, contracted bulbocavernosus muscle. Now, I mentioned the partner factor too. You can think of this like threading a needle. What happens if the thread is floppy? You have to lick it, you have to twist it, you need to give it some tumescence. It's hard to get a floppy thread through the eye of the needle. Now I know we're on a bigger scale here, but one of my patients said it best. it's very difficult to stuff a marshmallow into a piggy bank. And it doesn't feel right. So, not to make light of erectile dysfunction, it's a very common problem. As many as 30 to 40% of men have it. It's correctable, it's treatable, thankfully. But being approached with not a full erection doesn't feel right. And the muscle, rather than opening, actually closes, and then you just can't thread the needle. So this is why you have to ask about the partner. So what do we know about how to treat vaginismus? The science isn't great. There's a good Cochrane review from 2012 on this. Most of the studies did not meet criteria. Those that did were using systematic desensitization, which is an umbrella term for a variety of modalities. No pharmacologic studies met review criteria, and to my knowledge, none since would have met criteria for this review. And there's not enough evidence to suggest that systematic desensitization, even blessings, including dilators, is more effective than group therapy or self-dilation alone. But do we use vaginal dilators to help women overcome the problem of vaginismus? Yes, we do. I'm happy to explain how in our clinic we do this. And many women do find benefit even in just using these tools to understand their anatomy and help make it work. Bless you. One of the best tricks I've learned, I do fit patients for dilators in my clinic, so I have a set of these dilators. By the way, be careful, the companies market them as sterilizable, reusable. Turns out they don't meet that standard, so if you use it in the clinic, you got to give it to the patient to take home, or patients can get direct-to-consumer models. When you are inserting a speculum or a vaginal dilator or anything into the vagina, the thing to say is bear down. Sometimes we tell people to cough, like when you do a LEEP biopsy. Did anyone teach you? That's what I learned in residency, like cough, and you do the biopsy right then. Saying to a woman in a dorsal lithotomy position with a medical student, a resident, attending, standing there, relax, is a little insulting for some people. It's not relaxing. But saying, could you bear down? I'm going to insert this, bear down when I insert it. It will open that muscle. It's a Valsalva maneuver, and it makes the exam easier. And once the dilator's in there, you can say to a woman, bear down to push it out with a hand mirror. And she sees it come out, and now she's like, oh, that's what you mean by bearing down. It's harder to get that biofeedback with it going in. It's a little weird, and my patients are like, this is a little weird, but it's really helpful. So we use dilators. What I mean by biofeedback is giving patients the hand mirror, giving them that feedback. Yes, that's bearing down. You can see it coming out. I want you to do that same maneuver when something's going in. Pelvic floor physical therapy is extremely helpful. Women's Health APTA is the place to look. I'm sure you have pelvic floor physical therapists here. Not all pelvic floor physical therapists are trained in sexual dysfunction. Most are trained at least in urinary function and pain. We have one of our tools on the website is, are you my pelvic floor physical therapist? And it's a list of questions a woman can ask a physical therapist who you find on APTA to ascertain whether she's comfortable treating a person who's presenting for physical therapy for sexual dysfunction problems. Because that last mile can be difficult sometimes. And what about vulvovaginal dryness? So one of the biggest problems that is not well detected in gynecologic practice is hyperhygiene, especially post-menopause, especially in women on aromatase inhibitor therapies where they are seriously deprived of estrogen. So there's just the quality of the epithelium on the vulva and the vaginal mucosa is really stressed. Hyperhygiene is just an incredibly reversible problem. There is no good evidence that using soap, certainly not perfumed soaps or douches in the vagina or on the vulva, are helpful for anything. These are the mucosal surface of the vagina cleans itself like the eyeballs or the nose. And I use that to say to my patients, would you ever use that Summer's Eve on your eyeballs? Of course not, they say. Would you use it inside your nose? No, that would be terrible. Okay, please then don't put it in your vagina. And one of the reasons why they're washing is because the washing causes disruption in the normal microbiome or understanding of the vagina and the vulva. That gives an odor, then they wash more, and it's a vicious cycle. So in patients living in public housing, at least in Chicago, oftentimes bathe rather than shower because you can better control the temperature of the water. But then everybody in the household is bathing, so they're scrubbing, they're scouring the tub with bleach or Comet or other products like that in between every bath, so they're kind of soaking in it. And so we have to educate about what that does potentially to their vulva and vagina. So eliminating hyperhygiene, treating contact irritant dermatitis, a little bit of over-the-counter hydrocortisone cream can go a long way can be a way to really get on top of easily correctable problems. There are no FDA-approved moisturizers or lubricants as prescription products, but there are hundreds of these products worldwide. Now, of course, estradiol and related products, and I'll show you some of the other prescription products, do work to help improve the moisture in the vagina, but products that we call moisturizers and lubricants are over-the-counter products. Interestingly, they are treated by the FDA. In the past, they've been treated by the FDA as cosmetics, and now they're classified as devices. And they are held to a different standard of quality, safety, effectiveness, etc., in terms of being able to sell these to women. Moisturizers are maintenance, using them every couple of days to try to keep the vagina moist. Women who have had cancer and don't want or are not eligible to use estrogen-containing products oftentimes are using these products. Replens is a commonly marketed one, which has not been shown to be better than placebo. Hyalogine is a hyaluronic acid product. I only mention it by trade name because it's the only one I know of. I do not own stock in that company, and I haven't studied it myself. There is some literature on it. Hyaluronic acid is a naturally occurring molecule in our bodies that helps to maintain hydration, and I have found patients, many of my patients do well on a hyaluronic acid every couple of days. Memorial Sloan Kettering is doing a study looking at it everyday use that I've seen in abstract form, but I think will come out soon. Lubricants are used for love. This is my mnemonic. Moisturizers for maintenance, lubricants for love making. Sorry, it's a little silly, but you got to keep these things straight. They are intended to reduce friction, but they don't help with that dryness that you have sort of on an everyday basis. And there are a whole variety. At one point, my lab was on a mission to try to get one of every lubricant in the world, and we filled up the lab with hundreds of these products, most of which have ingredient lists with 20 or 30 ingredients, none of which you would put in your food, most of which you can't pronounce, and some of which we know are common irritants like parabens and glycerins. And there are water-based lubricants. We use those in gynecology practice, so women think those are best, but they're not necessarily best. They dry out quickly, they get sticky and tacky, they're bacteriostatic, which our microbiomes do not need. So you have to say, I'm using this here because this is what we need for pregnant ladies. That's pretty much why we're using that thing. But there are other lubricants that are more effective. If you want more friction, like with vaginal laxity, use a water-based lubricant. If you want less friction, choose a silicone-based lubricant or an oil-based lubricant. And I'm a huge fan of coconut oil. It comes in regular, it comes in no scent, and you can use it in your kitchen, and you can use it for sex, and it's okay for oral sex. It works also as a moisturizer. And there is some research on coconut oil. Okay? What about atrophy? So you obviously know we could have a whole lecture on this topic, but I don't want to just miss a chance to quickly review, and we would like you to have a couple minutes for questions. This patient you see is a patient of mine, 5 years of tamoxifen therapy, 3 years of aromatase inhibitor therapy. It is not easy to fully appreciate the loss of architecture, but you can see the pinpoint vaginal introitus. Her clitoris was essentially flat. You can see the glands, the hood is retracted, very little demarcation between the labia. Many of the aromatase inhibitor patients look like lichen sclerosis patients in terms of loss of architecture, and I see people shaking their heads. Yes, not well described. We have very little, in fact, I don't know of a study yet that's prospectively assessed the vulvar anatomy before aromatase inhibitor treatment and then tracked it over time, visually, histologically, and then look to see, does it reverse when a woman comes off the aromatase inhibitors? We need to do that study. By the way, maybe between us we'd have enough patients to do it together. But women are losing serious architecture and function, but not being counseled about it. That's not to say aromatase inhibitors aren't a good thing and that we shouldn't use them, but yes, we should understand the effects and do something to mitigate them if at all possible. Not all women we can't assume a linear relationship between age and no estrogen in the vagina. So it's like, oh, how old is she? 75. Oh, that explains it. Give her some estrogen, in the vagina. The benchmark research on vaginal estrogenization came from the work of Dr. Mizels in Canada in the 1960s. Those were patients who presented postmenopause with gynecologic problems and complaints. They were not a probability sample of the population. And this is largely pre-hormone therapy. And so what Dr. Meisels, who was a pathologist, and his team found was that there was an age-related decline in vaginal estrogen levels for that population, for people presenting with problems. When we look at a population-based sample, and that's the top line, this was from our National Social Life Health and Aging Project, where women gave us vaginal self-swabs. It was a home-based study. They swabbed their vaginas, and we did the cytology. In a population-based sample, we do not see an age-related decline in vaginal estrogen. So it is important when the patient presents with new symptoms, especially several years after menopause, new symptoms of vaginitis or complaints, that we look for the dermatitis, we look for other causes. We don't just slap estrogen on. Back to it's worthwhile to do a physical exam. So what are our choices for vaginal estrogen? We have cream, we have rings, we have tablets, and we now recently have a vaginal suppository. This followed the introduction of DHEA suppository, and I think it's good to have a suppository. Some people really feel the cream is messy. There is lower pricing than it was in my last talk 1 week ago at Rush University. You can go direct to the producer of the vaginal suppository and through their own pharmacy purchase the treatment for $35. Many insurances have not yet started covering it. It was in the hundreds of dollars if you don't get it that way. And what about other vaginal therapies? DHEA is a vaginal suppository. It converts to estrogen in the vagina. Some people, I've heard it talked about as an orgasm-promoting drug. There is no evidence for that. But 30% of the time, placebo works in sexual function studies. So 30% of people might have better orgasms just by placebo alone with the DHEA. Or maybe it has that benefit, it just hasn't borne out yet in studies. Lidocaine ointment can be helpful as a Band-Aid, especially to enable physical therapy, but it's not a long-term treatment at the opening of the introitus to treat a problem. And vaginal CO2 laser is an exciting alternative because it's non-hormonal. It doesn't have to be used every day or twice a week. But I have an exclamation point here because the FDA has raised some concerns about safety and about the marketing of the product. And my read of the science is that we have insufficient evidence to really fully counsel people appropriately about benefit versus risk with this treatment. And it's a costly treatment. I think it's being offered here, and so I'm happy to engage in further discussion about that. But I think we need more science on that front. And I think it's important to share with you the FDA warning, and there was an update from the FDA a few months ago where they were sending letters to companies about how they're marketing the product. I would love to talk to you about treatment of low libido, but then there won't be time for questions. I will make sure you have all my slides. I only have a couple slides. Bottom line is flibanserin is not much better than placebo, has side effects, and it requires the permission slip from the patient, the doctor, and the prescribing pharmacist. I have had no patients take me up on this as an option, and we've been able to address libido by addressing the underlying problems, which is usually pain. So what questions do you have for me? Yes, thank you. Okay, yes.
So I have a comment and a question.
Okay.
The comment is, I've had a few people ask about Addyi,
Yes, the flibanserin drug.
Yeah.
Mm-hmm.
And I tell them that it will do nothing for his bad breath or his beer gut. Okay.
Okay.
That's the first thing.
But we shouldn't assume that he has that.
Well, no. I mean, I'm
Okay. Okay. Yes.
But patients who use coconut oil for lubricant or for moisture, what effect does that have on condoms?
Well, you know, the saying is, or the teaching is, that oil-based lubricants can break down condoms, and so that, and in the handout which we put on Woman Lab, we do have that caveat around the, you know, what's compatible with condoms, even what's compatible with fertility based on limited evidence in terms of the moisturizers and lubricants. Most of my patients are not using condoms because the patient population I treat, but that would be a cause for concern, in which case a silicone lubricant would be a better option.
So a vegetable-based oil is still destructive to latex the way a or get a petroleum-based lubricant?
Yeah, I do know the answer. I don't have a scientific answer to that. I'm relying on, I think, probably old evidence about petroleum-based compatibility with latex condoms. There are alternatives to latex condoms, but if you're having dyspareunia and dryness, the thicker the condom, the harder it is to work with. There are also female condoms, but they're also latex, right? Yeah. So some science is needed. Great resident research project. Yes.
Do you have any experience with a product called Julva?
No, what's that?
It's a combined vaginal moisturizer lubricant.
Okay.
It's supposed to help with atrophy. I just had a patient who's had recurrent UTIs, chronic atrophy, couldn't tolerate estrogen, and she came back after 6 months in Florida saying she used this Julva product and it's like solved all of her problems.
Wow.
And I've just been Googling it and it's new to me, so I'm just wondering if you've heard of it.
No, I haven't heard of it.
It's available on like Amazon.
Yeah. Well, again, and like I said, 30% of the time a placebo works. Believing something works is a big part of it working. We don't, and patients frequently bring me different, the names of things that I look up with them. We look at the ingredients. Not tolerating estrogen is interesting. I haven't heard that, and so I wonder why. Yeah. Yes.
It's a good lecture, but I understand the topic cannot be covered completely.
Right. Yeah.
But I have a question about two entities. One is psychoanalysis.
Yes.
Does anybody uses it? And the second one is hypnosis for treatment and diagnosis. Hypnosis.
Well, I love your questions because I myself have a holistic approach to treating disease. And one of our practitioners is an acupuncturist. She was a nurse oncologist who became an acupuncturist. The evidence for using acupuncture to treat sexual dysfunctions is limited. And I've had many patients use acupuncture for other cancer-related problems like pain, lymphedema, who feel that it has benefited their sexual function. I have not used hypnosis. I don't have a hypnotist in our group, but I would be open to that possibility. I don't think it's going to address necessarily hypertonic or spastic bulbar cavernosus muscle alone, but many people have psychic pain from suffering with these problems, and perhaps it's a modality that could address psychic pain. I would be open to it. And the risks seem to be relatively small, right? And then, of course, sex therapy is a very useful adjunct, and sometimes really the first modality. I strongly recommend you work with a certified sex therapist. They should be ASEPT certified. I don't know of another certifying organization that meets their standards, and this means they go through training and they go through at least 1,000 hours of supervision by a trained sex therapist. We have a great sex therapist, Dr. Shirley Barron, who was at Harvard at one time, who's trained maybe 30 people in our region, so we are replete with qualified people. But the evidence is also limited on sex therapy. At the same time, it is many couples find it to be very helpful to have some coaching on how to talk about this topic, because after a hiatus with no sex, there's an elephant in the room, and it can be hard to, just even initiate the conversation. So I work very closely with sex therapists. And psychoanalysis, I don't know the answer to that, but again, open. So few of our patients my patient population would be able to access psychoanalysis as a treatment because of cost. Yeah. Thank you for your question.
Yeah, and it's another thing is on your interpretation of Master and Johnson curve.
Yes.
We're missing one point at the end of the sexual cycle, its resolution.
Yes.
Which is equivalent to the similar response as vaginitis or vaginismus when it's at the beginning of the. So it's a very difficult sometimes to diagnose the different stages of sexual dysfunction.
Yeah, I'm not sure that what I'm going to say addresses the comment that you're making, but it does remind me to say one practical tip for women, especially women who've had dyspareunia, is not to orgasm may not happen synchronously with vaginal penetrative intercourse. That I think is an important point to share. Only about a third of women, a third of the time, have that Hollywood orgasm. Foreplay is a way that a lot of women achieve orgasm in sexual encounter, and for some couples, it's most pleasurable for the woman to have an orgasm first before penetration. In a case where there's hypertonicity in the pelvic floor and painful intercourse, my recommendation is, if you can, change up the repertoire so the female orgasm happens after vaginal penetration. Why? Because the physiology of orgasm does result in contraction of the uterus, the vagina, and the vulval cavernosus muscle. So things are actually even tighter. So you prompted me to say that, and forgive me if it wasn't exactly on point to your question. But we've gone past time. I don't want to hold you hostage here, but I want to thank you so much for the opportunity.